Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing LGBTQ Healthcare. On a previous episode of Well Said, we discussed the diversity of the LGBTQ community and some of the challenges members of this community face while seeking healthcare. In today's episode, we revisit this topic with one of our prior guests, Dr. David Rosenthal. We'll continue the conversation. We'll discuss the key role that healthcare providers play in improving access to care for members of this community. As I said, once again, my guest is my colleague, Dr. David Rosenthal. Dr. Rosenthal is Medical Director at the Center for Young Adult, Adolescent, and Pediatric HIV, as well as the Medical Director for LGBT Health and the Center for Transgender Care at Northwell Health. Dr. Rosenthal is also an assistant professor at the Zucker School of Medicine, and I'm delighted he's with me here again today. So, David, welcome back to Well Said.
Thank you so much, Ira. It's great to be here with you again.
So, can't let the opportunity pass to say that we are now past the 2-year mark into the global COVID pandemic. So before we get into the topic at hand, I just want to ask how you've been holding up and how the pandemic has affected the work that you've been doing.
So I think like all of us, I think it's made an enormous difference in what we're doing on a day-to-day basis. Things shifted obviously rapidly to telehealth and then back. Thankfully, we've been able to kind of really address the needs of our patients throughout the entire pandemic, and we've really utilized a lot of resources and kind of novel approaches to really make sure we could bring healthcare to patients using telehealth and using services like LabFly through the core laboratory at Northwell Health, which lets us bring laboratory testing to patients' houses or to their places of business. So we've really kind of shifted bringing healthcare to people in other ways. And I think the other big change that I've seen is that the effect on mental health care of my patients, especially my transgender patients, has been phenomenal. And kind of the period of exclusion when people were not in schools and people were at home made an enormous impact on our patients and certainly created a lot of challenges. But thankfully, I feel like we're starting to come out of that period and look towards the future. And I think that hopefully we'll be able to take some of the opportunities which existed, like being able to use telehealth and remote health care as possibilities, and be able to grow on that and see how we can continue to provide better health care for all of our patients.
All right. Well, that's great. I'd like to provide some context for our listeners. So let me start with something really super basic and have you define what we mean by LGBTQ.
Great. So I often actually even use the mnemonic LGBTQIA. So it's lesbian, gay, bisexual, transgender, queer or questioning, people that are allies, and then people that are also intersex. And I usually put a plus at the end of it because the reality is this community is continuing to grow. And one of the terms that we're seeing is really people are identifying as different subsets of this community and different subsets within the other subsets. And I hope we'll get a chance to talk about kind of the difference between LGBT people and trans individuals as well later on in this conversation. But I think that that's really essential for us to understand the difference that people have and that this rainbow is made up of a lot of different colors and truly has people that have different identities as part of it. And so I think that's really an important piece for us to understand.
Yeah, well, I'm glad you brought that up because while that has become a common shorthand, as you said, it really encompasses a very wide range of individuals, and I suspect those individuals have a very wide range of medical and healthcare needs. So maybe we should start there. What's your take on whether we should be lumping all of these folks together or whether we should be more careful in splitting them into separate categories or communities that deserve special attention?
So I think the answer is both. I think when we're taking a look at social determinants of health and we're taking a look at minority populations, we always realize that there's certain needs that kind of transcend different subpopulations, but then there are certain needs that exist within other groups. So if we take a look, we often will say something like communities of color, referring to individuals, and clearly there's many different subpopulations that need different things in our communities of color from a health equity perspective. But when we're taking a look at the LGBTQIA plus community, we're really also seeing multiple different groups of people that have different healthcare needs, and we need to address them collectively as a group, because I think there is power in being able to say that we have addressing this large sexual minority population that really is here in the United States and in New York, but also to then make sure we're specializing the care that we're providing to the individuals that in that group that meet their specific needs. And the biggest split that I think exists is really as we take a look at individuals, for example, that are lesbians. We know that they have a lower rate of mammograms and cervical cancer screens than other people that are not lesbians. We know that individuals that are gay have a higher risk of certain types of cancer, have higher risks of smoking and certain types of substance abuse. And we also know that people have to address those needs. And with the trans and gender nonconforming and non-binary communities, they also have specific healthcare needs. A lot of times they were turned away from the healthcare setting. They avoided healthcare altogether because they didn't feel they could talk to their providers about things. And in the historical reasons, really people felt that they really couldn't even access healthcare and that everything was blamed on their transgender status, and that really wasn't providing the best care that we could provide.
So that strikes me as a very diverse set of needs. What is it that you think this community shares across all of those different subcategories?
I think the thing that they share is I think they face social stigma and a lot of different disparities that exist specifically for the community. And so we do see higher levels of substance abuse, higher levels of certain types of cancer that we believe exist in this community, higher levels of cigarette smoking and tobacco use in this community as well. So I think that in addition to that, we also have a lot of the stigma that exists and the fact that people do not feel comfortable addressing certain aspects of their life with their healthcare providers because they're afraid that they're going to be judged by their healthcare providers that may or may not be able to help them or understand the life decisions and choices that are part of their everyday.
Yeah, I remember when we spoke about this a couple of years ago that was a central part of our conversation, that sense of not feeling welcome within the healthcare delivery system and the associated stigma that was placed on members of this community. You expressed some optimism about that a couple of years ago. Do you think there's been progress made in that regard?
No, I think it's great. And I think there actually is some great things that are happening. I mean, we've made really significant changes. 5 years ago or 6 years ago when we started this program in 2016 at Northwell Health, there really was very little knowledge, very little discussion, and really there was very little information that was being shared. And the reality is that healthcare providers like you and I didn't get training about LGBT health when we were in medical school. And so I think what we've been able to start doing is starting to move that discussion. And part of that's happened because of changes that have occurred within social context, the fact that you can't, that there's TV shows, there's things on the radio, there's ads, there's books, there's a lot of discussion about the LGBT community that we're seeing more popularly. And I think that that's created a thirst for knowledge and a desire to learn from providers that are trying to kind of gather this information. And just like when a new drug comes out, providers need to continually learn new medications, or when a new procedure comes out, surgeons need to learn a new surgical procedure. What we're seeing right now is people are learning new ways to get sexual histories and new ways to talk to their patients that really address their patients' needs based on their LGBT status. And I think that there's a desire for many physicians to gather that information and to really utilize it. So it's just a matter of continuing to raise awareness and to share knowledge.
You know, I really like the way you frame that as kind of tools that clinicians need to meet patients where they are and to be able to more effectively relate to them. I mean, it's in some ways what comes to mind when you say that is I think the healthcare system has become more aware of the fact that, for instance, not everybody speaks English, right? So we need to improve our ability to communicate to people in languages that they're comfortable with. And what I'm hearing from you is we need to be able to speak to patients about their sexuality and their sense of sexual identity in a way that makes them comfortable trusting us.
Absolutely. That's exactly where I'm heading. And very often we use, and very often in the healthcare setting, we talk about REL, or race, ethnicity, and language, and capturing those demographics. And I think that we've made a similar approach recently within Northwell Health to really capture other demographics like sexual orientation and gender identity, and to normalize the collection of this data so that we can then be able to apply healthcare in ways that make people feel comfortable. If you don't know what someone's preferred language is, you can't address them with that preferred language. But if you know that information, you can then utilize it. And it's the same way if we ask kind of and routinize the request of information about people's gender identity and sexual orientation, then we can have that information at the onset, and we can really kind of make that part of the fabric of the healthcare we provide, rather than assuming that everyone is going to be intimate with the same parts of their body, or that everyone is going to love people that are of an opposite gender of themselves.
Yeah, and just by way of clarification again for our listeners, you and I have been using the terms sexual orientation and gender identity, and I wonder if you would just define those for us.
That's great. So sexual orientation is really who you're romantically attracted to, or who you're interested in romantically. Whereas your gender identity, the way I describe it, is that it's really not something that is external. It's how you conceive of your own gender identity, your own sense of gender, masculineness or feminineness. And some people really identify more on the gender binary, which is really talking about people that are men or women, and some people are kind of more gender fluid or gender queer or gender non-binary. And I think that it's important for us to realize that there's a lot of different definitions for gender identity. So the way I always describe it is that your gender identity is what's between your ears, not what's between your hips. And your sexual orientation is who you are interested in romantically, affectionately.
And again, well, I think that's a really clear explanation, so thank you for that. How would you define gender fluidity?
Great. So really what happens is people that are gender fluid are individuals that don't necessarily identify as one gender or another. So I actually saw someone the other day that says, I often feel more masculine, but today I really felt more feminine, and it was okay for me to want to wear a dress today. So I think that the reality is we are very good at putting people into bins or silos. And we used to kind of define people as either having to appear and identify as all male or all female. And I think that what we're understanding with people that are gender fluid is that sometimes they're more masculine and sometimes they're more feminine. It may be an issue, it may be a day, it may be a feeling, it may be a topic. But instead of necessarily defining people strictly in two separate categories, we need to realize there are other individuals that fall within that category. And I think in a lot of ways it's something that's kind of existed throughout culture for really all of human history. If you think back to Native American culture, there's been a concept of people that are two-spirited or two-spirit, and those are really people that identify kind of as gender fluid or that identify as masculine or feminine. And there's similar concepts that exist both in Greek and Roman history. So from a sociological perspective, the concept of being non-binary or gender fluid has certainly existed for a long time. It just hasn't been very prevalent in Western culture in the past several hundred years.
I've heard you speak very effectively on these topics in other settings and use the phrase gender affirming. What do you mean by that?
Exactly. So I think one real important thing is that we provide gender affirming healthcare, because the reality is that we want people to be able to receive healthcare that affirms their gender identity, how they see themselves. Just like you can't look across a reception desk and be able to identify if someone is African American or Hispanic, we can't necessarily tell based off the way someone appears. We really want to ask people what their gender identity is, and then we want to make sure that we're able to provide affirming healthcare that really meets those needs. And so I think that the key concept is that we understand where the patient is, we figure out what we need to do to be able to address them, and then we can basically affirm the decisions that they're making in their life and provide the best health care that we can to them based off of their life, rather than based off of a idealized or conceptual image of someone who is heterosexual or cisgender.
You mentioned before that the medical community may not be any more comfortable with these ideas or any more knowledgeable about these issues than the public at large, and yet it's so important for us as healthcare providers to create that sense of trust and safety and to be a gender-affirming organization. What steps have you been involved with to help educate healthcare professionals about treating members of this diverse community?
Well, the first thing that I always talk about education, and I think this is true for anyone who really engages in education, is education never has an end. So I think that one concept is we can continue to always learn and continue to always grow. So we've made a lot of phenomenal strides and made a lot of phenomenal steps to kind of provide information, but we certainly have additional growth to happen, and we can always continue to gather knowledge. Some of the things that we've done is really we've been able to talk to physicians in large settings by giving grand rounds. And so I've spoken to OBGYN, to surgery, to anesthesiology, to internal medicine, and to pediatrics across the entire health system, really talking about these issues and being able to inform them about some of the terminology that we should be using in these conversations and ways that we can kind of educate others. We've engaged and worked closely with the emergency department service line to really be able to work closely with them and make sure that when patients are coming into the ED, into the emergency room, that they're able to get the kinds of care that they need that really helps understand. But we're also helping to kind of change the fabric of the infrastructure of our medical record systems to make sure that we're able to ask questions about people's gender identity and their sexual orientation early on in the process when they occur at registration. And so as they come into our institutions, we're able to have that information at our fingertips and then be able to utilize it as time goes along to be able to make sure that we can provide the right kind of care for individuals. So the work that we're doing is not just based in educating providers, but it's also about educating our security and educating dietary and educating our radiology techs and our environmental engineer team and all of the people that really take care of patients here at Northwell Health. So this is the work that we're engaging on, and it's a process, and we're continuing to make more and more strides to educate and provide information to more and more healthcare providers throughout the entire healthcare system.
Yeah, and I can imagine that there's an element of that, of not only educating people who are gathering this information, but creating systems of care so that that information is seamlessly propagated so that people aren't repeatedly challenged or asked these questions over and over again, or that people don't act surprised when somebody answers a question in a particular way, right? That we're improving our internal communication around these issues as well.
Absolutely. And so part of that is going to be systems-based change that's going to require changes of infrastructure using technology. And part of it is going to be an old-fashioned, what we used to call passing the baton. We used to kind of hand off information from one healthcare provider to the other. So while we're continuing to work on the propagation of the information digitally from system to system so that everyone can get that information and know how to access it, right now we're using a mix of both digital propagation where information goes from system to system, and we're doing a great job of that in our ambulatory practices. And on our inpatient services, we're providing really good information that we're collecting, but we haven't gotten it to every endpoint also, and so we're using a pass the baton methodology where we verbally hand that information off from provider to provider to make sure that information is then relayed as the patient goes from provider to provider.
Yeah, so we've been talking about your work, about our organization. I want to zoom out a little bit and talk about some things that have been in the news lately about healthcare for transgendered kids in particular. And what I'm referring to is the move in some states, in some areas of our country, to actually limit the kinds of treatments and interventions that physicians can provide to transgendered kids. And I wonder if you could educate our listeners about what's going on and then offer your perspective on that as well.
Great. So there are multiple different legislative and governmental processes that are going on. One, that you're not allowed to possibly teach people in elementary school or talk about individuals that are not heterosexual or cisgendered. So you can't even talk about someone. So if you have someone in your classroom, for example, that identifies as a girl, the school would not be allowed to discuss or be able to make accommodations for that child in that classroom if they were born or signed male at birth. So that's one issue that's going on. There's another issue that we're dealing with as well, where it would be illegal or be considered child abuse to be able to provide gender-affirming care to individuals. And I think all of these governmental approaches are very problematic, because I think what we need to do within healthcare is that we need to maintain the sanctity of the doctor-patient relationship that allows a knowledgeable provider to be able to speak to a patient and understand what's going to be in that patient's best interest and to provide the best health care that they can to that child or to that person. with the parents involved in the process. And so I think that I'm very against kind of setting legislative or governmental limits on what we should be talking about or what we should be doing or what kind of health care we can provide, because I believe that we should address every situation and every patient uniquely and individually and address their needs and figure out what's going to help them be happy and healthy. We know that a very, very large proportion of transgender youth under the age actually think about and attempt to commit suicide, somewhere between 42 and 58%, depending on the various statistics.
Oh, my God. David, stop right there and just repeat what you said, because that's a really stunning statistic.
Right. So somewhere between 42 and 58% of transgender youth contemplate or attempt suicide. And
Wow.
so it's a really frightening concept. And so what we need to do is we need to create safe environments where these individuals can get the kind of health care and the kind of support that they need from their schools, from their families, from their teachers, and from their healthcare professionals. Because our goal and our role as healthcare providers is to help keep people healthy. And there's multiple different ways to do that. And I think it's really essential that we're able to create education and really help people be their most authentic selves, but also be themselves in a way that lets them be healthy and happy. And so that's why this is so, I have to be honest, it's very frustrating for me as a healthcare provider for someone that's never met my patient that I talked to today and that I was looking at in the room to tell me that I don't know how to provide the right kind of health care. And I think that we need to make sure that we're able to provide the kinds of services that really are based on academic and intellectual standards and outcomes and the best research that we have, rather than based off of politics. And
let me just be explicit about some of those kinds of treatments that we may be referring to, because I do have a follow-up question, but I want to make sure we're talking about the same thing. So we're talking about among a wide range of potential treatments and services, but I think that the things that have gotten people kind of upset or have led to these legislative efforts are things like puberty blockers for kids so that they don't take on the secondary sexual characteristics of the gender that they were assigned at birth, or hormone treatments, possible surgical gender-affirming surgeries, things of that nature. Is that correct?
Absolutely. And I think that when we're talking about those things, we just covered a range of ages that are very different. So I think that the reality is that when we're talking about a transition for someone, we really talk about a process. And that process, the way we idealize it and think about it, really begins with a social transition. It begins with them identifying as someone that has a different identity than they were originally assigned, their gender identity than they were assigned at birth. And often that includes wearing different clothes, cutting one's hair differently, being able to do social transitions, possibly using a different name or different pronouns, having people address them in ways that they feel comfortable. All of these things are really non-medical interventions, and they make an enormous difference in our patients' lives. Then there becomes a point where, for example, if someone's starting to have menses, and then that patient is having such difficulty being able to manage that, the dysphoria and the psychological burden of that is actually causing the patient to self-harm or to cause challenges for themselves. What we really need to do is we need to figure out how we can really help that person. And so by stopping puberty or pausing puberty using a puberty blocker, what you're able to do is able to kind of halt puberty where it is and be able to let the person just continue to be the way they were when they were prepubescent, like they were 9 or whatever. And that gives an adolescent or a young adult time to kind of develop psychologically, be able to figure out who they are better, and to do things while we're kind of holding puberty back. It's sort of like a cassette tape, if you think about it. And so what happens is
cassette tape? What's that? Sorry,
that's
just
right.
kidding.
And I think that's exactly it. So, I mean, I actually, it's funny because I'm in the rooms and I always am talking to the parents and I talk about a cassette tape. And then I say an MP3 if we're talking to one of the younger people.
Much better.
So the cassette tape, I like the analogy because what happens is it goes from reel to reel, from one place to another. And when you press pause, the cassette tape, the tape doesn't rip. It doesn't stop. It doesn't get damaged. It doesn't get ruined. Nothing. It just doesn't move forward. And that's in a lot of ways what a puberty blocker is doing. And so it'll pause things just like if you press the pause on the MP3. But the thing is that it's not that there's anything that happens while it's paused. It just stays there. And then the thing is if you unpause it, then the cassette will move forward, or the song will continue forward if you're listening to your MP3. And so I think that's the concept that you want to consider is puberty blockers give us time to let young people be able to figure out more who they are, what they need, and to be able to kind of give them that time to be able to kind of create that bridge.
But I think the sort of boogeyman that a number of politicians have used to rail against the kind of gender-affirming care that you're talking about is this idea that minors are going to get irreversible surgical interventions so that their bodies match their gender identity. And
so I really don't. I'm sorry. Go ahead.
Yeah. No. So what's your response to that?
So I really don't think that that's what's happening. The reality is like you said, we tend to start with social transitions. Then we'll consider blockers. We may consider hormones. And in some situations, we may consider some surgeries, but not even that many surgeries for people that are still minors. So I think that the reality is that this is a process that we work through, and life is a journey. And just as these young people are growing up, then they're able to kind of make additional decisions. But it's not like you're going to have someone who's a young child that you're going to be doing surgery on for gender-affirming surgery. That's really not the plan, and that's not really part of any of the care models that we participate in. I think people have a concept that you're suddenly going to have a 13-year-old that's going to start having gender reassignment surgery, and that's completely ridiculous. There's no place that's doing that.
Yeah.
So I think that we need to realize we're talking about people kind of what's going on, but when you have a 16-year-old who's identified as being a boy for, the past 7 years or 5 years, and they have very large breasts that are really causing them to be very uncomfortable, a lot of dysphoria, for people to make fun of them, for them to not feel comfortable going out in public, then the question is what are we going to be able to do to be able to help those individuals? And it's just like we have for some individuals that are very large-breasted, sometimes people before they're 18 will also have breast reduction surgery for similar reasons because it's important for their quality of life. And I think that we need to make sure we're realizing what we're talking about is this kind of thing for minors. We're not talking about other kinds of things for minors. And it's not even that common that we're talking about this until we get into the really latter parts of adolescence.
So what I'm hearing is people are making political hay out of this, but it's in some ways much ado about nothing.
I think that that's true in a lot of ways, and I think people say things, and I think people have concepts of things that are not truly based in reality, because I think that the right way to provide gender-affirming care and the way the standards are built to provide gender-affirming care is in a progressive, stage-wise manner, and it's based on the child's development, both their physical, their pubertal development, as well as their psychological development that's going to help drive which changes and outcomes we're going to be doing and how that makes a difference to be able to address their overall physical as well as psychological health.
David, speaking of psychological health, I want to pick up on that really stunning and disturbing statistic that you shared earlier about the rates of suicide attempt transgendered kids. Can you unpack that a little bit? What's that about?
Right. So what we really see is that often people feel very uncomfortable in who they are. So there was a study that was done where kids filled out a bubble form asking all sorts of questions while they were in their school, put together by the CDC. And this is an annual school population survey. And we take a look at all sorts of things. Are you sexually active? Have you been tested for HIV? Do you use marijuana? Do you smoke? Do you drink? It's important that we're able to take a look at that survey in schools all across the United States, as well as Native American tribes all over the United States. And we're able to understand and be able to gather more information about what we're seeing. And what we're able to understand is that transgender youth very often feel very uncomfortable. They're often bullied. They often don't feel that their families or that their friends or their schools really support or understand them. And what we need to show them is that that's not true. So our responsibility is to tell them there is hope. We do want to make sure that you are able to live as your authentic self and that you can really receive the kind of health care that you need and that we can help other adults around you understand and talk to you so that you can really receive the kind of helpful, supportive environment that you can have around you.
And obviously that goes beyond just what the healthcare system can provide. So can you share with our listeners sources of other resources that they can reach out to or other sources of information to help with this circumstance?
Absolutely. So there's a lot of great resources. The Trevor Project is a great national resource, and they have a hotline that addresses the needs of LGBT youth and has a crisis hotline that you can call, you can text, or you can reach out to anytime. There's also other resources that are available that can really help individuals. PFLAG is a great organization that provides support for parents that have transgender or LGBT youth of any kind, and it's really important for parents to be able to address and understand what's going on and talk to other parents that have kids like theirs and kind of help with that experience. We know one of the things that makes the biggest difference for youth is truthfully having a supportive home environment. And so creating understanding and knowledge within the home is essential. And so also seeking mental health care providers or other specialty health care to kind of receive that kind of support and knowledge for those families is really important in your local communities. And one of the things that we do provide at the Center for Transgender Care here at Northwell Health is really to be able to provide those resources and help connect people to other community-based organizations. We partner with many LGBT agencies all over the region, and I actually saw a patient today from Westchester that we sent up to a LGBT agency up there, and we send people to organizations in New York City and all over Long Island and Queens as well to kind of provide that sort of supportive environment and socialization, which are so important for individuals.
Well, David, I want to thank you so much for sharing your knowledge and insights and for helping to continue to educate our entire community about these important issues. Really great content. I really appreciate your coming on the show today.
Absolutely. Thanks so much for having me. And like I said, education is always a process, and so it's always great to be able to continue this discussion.
I'm delighted that my guest has been Dr. David Rosenthal. And David, thank you again for joining me today. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.